you. Now we move to the second talk, the talk of distal humeral fractures by Dr. Mohamed Imam from UK. Dr. Mohamed, would you please start, sir?
Thank you, Professor Mohamed and Dr. Ahmed and everyone for the kind invitation. And thank you for the great efforts you're putting into these very well-observed, well-watched courses, which I think is crucial during these unprecedented times. I'm going to give this talk. I tried to make it as short as possible, which is hard with the title about distal humeral fractures, but I'll focus this talk on adults mainly, and we have to understand first thing, what are the goals of our initial assessment in these fractures. And distal humerus fracture represent 2 to 6%. Actually, it is 10% of all elbow fractures. Robinson in 2003 said it's 6 per 100,000. However, we know that now we're having more elderly population and the numbers are increasing day after day. And we have to understand that a fracture now in general is soft tissue injury that happen to have a bone broken underneath it. And that's the most accepted definition by the AO. The distal end of the humerus is flattened, expanded, transversely and rounded at the end. And you can see here the posterior aspect of the capitellum has no articular cartilage, and there is a downward projection of the trochlea, which is responsible about the carrying angle. If you look at the cross-section at the level of the fossa, this is really important at the level of the olecranon, because these are the two columns of bone on either side of the fossa, and these are the dense ones and offer good hold for screws. With the elbow in extension, the tip of the olecranon lodges in the olecranon fossa. So whenever you're fixing these fractures, you cannot have any plates or screws protruding at this area, because that will make the extension of the elbow impossible. When the elbow is flexed, you have to observe that there is 60 degrees anterior angulation of the articular portion of the humerus. And this forward angulation makes it difficult to apply plate to the radial aspect of the distal end of the humerus. So if we look at this AB view of the distal humerus, there is 94 to 98 angle between the longitudinal axis and the trochlear axis, and that's important to gauge. If you look at it from the medial side, the medial column makes about 10 degrees to the longitudinal humeral axis, positioning the trochlea slightly in front of the shaft. And if you look at the lateral view, the lateral column makes around 30 degrees angulation to the humeral axis. Therefore, the capitellum is positioned in front of the humeral diaphysis. So we are all aware of the AO classification. We can simply classify this into two categories. Category 1, which is partial articular and metaphyseal type A, and partial articular type B condylar, and the difficult complete articular type C fractures. Muller in 1979 and the AO classification, which has been widely used. However, I personally don't entirely agree, and many surgeons don't entirely agree with this, with the classification of fractures, with the AO classification of fractures. Chertsey was the first one who highlighted it in his book of operative rationale for fracture fixation, because you cannot include a classification of a fracture with different pathologists, different prognosis, and different treatment options at the same time. The fate of fractures around the elbow is determined by the anatomical part involved, by the degree of displacement, and by the degree of comminution. Thus, the problem lies in grouping A1 fractures with the difficult A2 and A3 fractures, B1 fracture and B2 fractures with coronal osteochondral P3 fracture, in which, of course, capitellar fracture can be a good reason here, because if you look, all three are intra-articular, but the only feature that B3 shares with B1 and B2 is that they are intra-articular. However, the mechanism of injury is different, the treatment option is different, and the prognosis is different. With type C, it's, of course, well known as complete articular fractures. So we can classify these fractures into two main fracture is having a prognostic point of view. It's more prudent to group fractures around the elbow into good prognosis and poor prognosis. And that's how I'm going to discuss these fractures now. The first one is a fracture of the lateral epicondyle. In adults, it's really extremely rare injury and occurs mainly as part of posterolateral or posterior dislocation of the elbow. Although, having said that, posterior dislocation of the elbow is usually associated with fracture of the medial epicondyle. In children where the lateral epicondyle is avulsed in varying portions of the capitellum, I opened this up a few times and you can see that the fracture surface is turned 180 degrees. Luckily, that's not the case when the elbow is reduced. Luckily, that's not the case in adults. And so usually we can manage this non-operatively. So what about the medial epicondyle fracture? This is the most common in children, as we know, but we can see in adults as a result of direct injury or an avulsion, and the fracture lie at different size. The ideal treatment for this is 3.5 cancellous screws, and it's easy through a medial approach. If it is if it is comminuted or small fragment, I use all suture repair, either using a suture tape or fiber tape, and always the approach is medial. The ulnar nerve in any elbow fixation should be identified, of course, before the reduction is identified and isolated before any reduction is attempted. So what about the lateral condyle fracture? In adults, this fracture is actually comparable to the fracture of the lateral condyle in children. And in our experience, it's always extend medially and always involves the trochlea. It's a major intra-articular fracture, must be accurately reduced and fixed to ensure preservation and restoration of normal joint function. We would prefer in Chertsey, and Mr. Khalil is an expert colleague of mine, 2 small 3.5 cancellous screws for fixation of these. I personally have very low threshold to operate on them, even if the initial displacement is minimal, because in all elbows, you have to move them. If you knock your elbow, fracture nothing, you lose 10 degrees. If you break it and put plaster, you lose a lot of degrees. So what about capitellum fracture? And that would be the last fracture with good prognosis here. The capitellum is a smooth, rounded, knob-like portion of the lateral condyle. It's completely covered by articular cartilage. The head rotates on its anterior articular surface when the elbow is in flexion. In extension, the radial head falls away from the distal end and lose contact with the capitellum. It's important then when you apply a plate on the posterior and lateral side of the distal humerus, because the radial head falls away in extension, we can place plate more distally on the non-articular surface, posterior surface, without causing an impingement in extension. However, you should be aware that the main blood supply always comes laterally. You can see in capitellar fractures, you can see here the double bubble, although it's very obvious here. This is a coronal shear fracture of the distal humerus. Most of them involve the capitellum, trochlea, or combination of both. They are uncommon, although I tend to, at least now I'm fixing one of these every month. So they are more, I think they were underdiagnosed in the past because usually there is less radiological evidence on x-rays. So it's always by clinical suspicion. In the last years, we've noticed progressive increase in their incident. Usually these, if someone had a fall on a semi-flexed elbow, that's actually the common cause or common mechanism of injury. Usually it is an axial load from the radial head to the capitellum. Or it can happen actually during the reduction phase of posterolateral rotatory dislocation of the impacted radial head and coronoid against the capitellum and the trochlea. So this is a well-known classification, which was classified by Bryan and Mori in 85. Type 1, which is a single large hemispherical osseous fragment, involving the entire capitellum. Type 2, osteochondral fracture with minimal subchondral bone. Type 3 is a severely comminuted. And actually, type 4 was introduced separately by McKee in 1996, and that is actually being referred to as the coronal share fracture. So Cooker approach is my preferred approach to fixing these. And however, you know, in all of these fractures, you have to have a CT scan for all of them with 3D reconstruction, and that's our standard practice in our unit. The approach you can decide based on the extension of the fracture. So as I said, Cooker, I'll use it, especially lateral collateral ligament preserving. What you should always be cautious here and take care of is that 60% of these have associated lateral ulnar collateral ligament or radial head fracture. So I tend to look for these at every time I'm fixing these. If the fracture is extending more medially, you can do the Cooker extensile approach, doing lateral column release, releasing the capsule anteriorly and posteriorly, and you can fix the medial fragment as well there. Olecranon osteotomy can be used if needed in order to fix fractures that extend way medially. So there are different ways we tend to fix these. In this patient, we have fixed with compression screws, headless compression screws, and the outcome is fine. Now I tend to actually use the biocompression screws, which is dissolvable screws in certain patients. You can see in that patient, it's the same fracture, and going medially, there was a radial head and a capitellar fracture, and you can see here eye images. You cannot see these screws, and actually, if you have tried to remove screws from a capitellum fracture, it's so painful. That's the advantage of doing this. And that patient has healed. Resorbable screws has the advantages, as I've mentioned, of not needing to remove. And of course, you can do MRI and CT scan without metal distortion. They are more expensive. There is a hypothetical risk of causing inflammatory reaction. And in osteoporotic bone, you might not be able to do compression. However, yeah, you have to select your patients before you do so for these fractures. So the third option, which was actually highlighted by Ring in 2003, he described these fractures to be articular fractures of the distal humerus. And it's mainly what was mentioned. It can, as in this patient, you can see here, it can involve the lateral column. And then in 2006, Duberly has proposed the name of capitellar and trochlear fractures for all of them. If there is a lateral column extension, you have to fix the lateral column, especially because of the posterior comminution. And so a lateral column plate would be advised here. So what about the bad prognosis, the big one? So if the fractures, type C fractures, and actually intra-articular types B and A3 fractures, they are a problem. Let's understand something. For all intra-articular fracture, you have to achieve anatomic reduction of the joint and correction of the deformity. As Mr. Khalil have said, that's how you reduce the risk on the articular cartilage. It's all about alignment. And if you, in order to prevent stiffness, all these fractures require early active motion. Prolonged plaster immobilization leads to irreversible joint stiffness. So whenever, even if I'm fixing a triple triad or one of these triple triads mainly, and I feel the fracture is unstable, I put an external fixator and allows the patient to move, because putting plaster on an elbow is doomed to bad outcomes. Different things have been proposed before. Sir John Charlie have highlighted that in the era where internal fixation wasn't a great option, and highlighted the importance of perfect anatomic restoration. Many surgeons now have proposed a consensus on managing these. For all intra-articular fractures, especially in elbows, immobilization leads to stiffness. Immobilization after ORIF leads to greater stiffness. You have to reduce the articular fragment. it's unlikely you'll be able to reduce it by closed means. Major articular depressions will not fill with fibrocartilage, and the displacement will be permanent. Anatomic reduction is necessary to restore the joint configuration. Metaphyseal defect can be bone grafted to prevent redisplacement. We use cement sometimes in order to prevent that. If there is metaphyseal or diaphyseal displacement, you have to reduce them to prevent joint overload. Joint congruency is our ultimate goal, to restore joint stability. Again, mobilize, 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 as you know, in order to achieve good outcomes. So how do we approach these fractures? You know, your resident registrar, fellow, whoever you have, can contact you. Oh, I have a distal humeral fracture. These are all distal humeral fractures, but it's completely different. Proper examination, make sure you're not missing any nerve injury. CT scan is mandatory to plan it. 3D CT scan have been proved in evidence to be a superior modality to help us preoperatively plan for our fixation. Factors to include: this is a old patient with low energy trauma, and this is a young patient with high energy trauma. So that has to be considered. You know, I have to understand whether it's osteoporotic or not. That dictate my treatment. What is the type of fracture, which the CT scan will tell me. We usually draw it on the board in order to understand what we are going to fix. We have to understand the degree of displacement and degree of comminution and joint involvement. Some of the extra-articular fractures are even worse to fix than the intra-articular fractures. Of course, we have to understand these are historical images. I haven't done any of these, but we have to understand that we have to understand that you have, if you're going to fix it, do it right, because fixing it with wires, putting the patient in plaster would not work. The gold standard now is double plating, and you will hear a lot about double plating in this fracture configuration. There are two forms: either the orthogonal way, which proposed by the AO, or the parallel way, which was first popularized by O'Driscoll in 2005, and then Sanchez Solito, both from Mayo Clinic, and I was lucky to visit both of them in 2007. The orthogonal technique, or known as the 90-90 plating or perpendicular plating, consists of placing two plates 90 degrees to one another, with the lateral plate on the coronal plane along the posterior aspect of the lateral column, and the medial plate on the medial ridge. The parallel plating, mainly applying plates over the two supracondylar ridges in the sagittal plane. Even if we define them as parallel, actually it is slightly rotated one towards the other out of the sagittal plane, so that the angle between them is not actually 180 degrees, it's 150 or 160, and that orientation permits to limit the soft tissue detachment of the posterolateral side and insert biocortical screws from one side to the other of the shaft. There are several studies comparing the biomechanical. Many found the lateral plate more biomechanically superior. Jacobson found that orthogonal plates are more mechanically superior. Some didn't find any differences, and these are two prospective randomized studies by Chen in 2010 and Lee in 2014, found no significant differences. However, they said double parallel plate configuration can be explained by mechanical evaluation. Clinically, now with the use of pre-contoured plating, locking plating, adequate surgical techniques, I think we can achieve superior outcomes in both of them. And personally, for me, it's all about the fracture configuration, and as a fracture configuration, because although I have low threshold to do the double plating. So how to achieve better outcome? So in order to achieve the outcome, and that was reported by many authors, 2004 O'Driscoll and Sanchez Solito again in 2007. It's all about the principle-based technique. So to achieve early range of motion with stable fixation, you have to maximize fixation in the distal fragment and apply through compression at the supracondylar plate. In order to do that, I tend to pass each screw through the plate. Each screw should engage a fragment, a fragment on the opposite side, so you make a fixed construct. Adequate number of screws should be placed in the distal fragments. Each screw should be as long as possible, understand the fracture well, and engage as many articular fragments as you can. And the screws should look by interdigitation by creating a fixed angle construct. And of course, place should be applied so that compression is achieved at the supracondylar level for both columns. Uh, Another option now, so that's the gold standard. Another option is reported also by Sanchez Solito in 2007, which is a shortening osteotomy, which allows to make good fixation in cases that otherwise, you will do a total elbow replacement. And in case of severe comminution of the metaphyseal level, supracondylar shortening osteotomy to apply compression between the articular and metaphyseal fragment in order to increase and maximize the contact area at the supracondylar level. So what about the elderly? Despite also improvement we talked about of regards to internal fixation, there remains a subset of fractures that are difficult to reconstruct because they have poor bone quality and articular comminution. And in these, the internal fixation shouldn't be pursued because it will fail. It's doomed to failure. So these cases are better treated by elbow arthroplasty. In our center, we do hemiarthroplasty and total elbow arthroplasty. Acutely, the first one who has highlighted the good short and long medium midterm results for this was Caminini in 2004 and McKee in his landmark seminal paper in 2005. Here, this is also another case. This is not my X-rays where fixation and total elbow replacements total elbow replacement has been done. With total elbow replacements, we should be aware with patients aseptic loosening, where osteolysis, all these complications are there, and this should be done in the right subset of patients. If you have a capitellum fracture with supracondylar fracture, Schatzker has proposed that if it is large, he put a wire or a hook and fix it from posterior to anterior. If I have that in one of these cases, what we tend to do is to release the lateral column from posterior and fix it anterior to posterior. Also, that's another option as well. New advances now for distal humeral fractures, arthroscopy for coronoid, for radial head and coronoid fractures has been reported and done. Arthroscopic assisted fixation has been attempted. Same applies for coronoid fractures as well. So how to fix this? Sorry for taking long, but it's a big topic. I'm trying to cover as much as I can. You can position your patient either prone or in the lateral position. I curve the incision to the lateral side. Always, whatever you're doing in the elbow, identify the ulnar nerve, because if you don't, the ulnar nerve will punish you. So one of the most common approaches to do is olecranon osteotomy. There are different techniques proposed. One technique is actually to put the plate, whatever you're going to use first, and then do your chevron osteotomy, and after finishing, you can fix it. What I tend to do now, which I learned during my fellowship writing for elbow replacement, is an osteotomy, transverse osteotomy with a phlebopone, and I can repair it with an anchor, which we're writing it up. Osteotomies work fine. You have to warn the patient that you're doing an osteotomy here, and the osteotomy actually, and I've seen it before, the fracture healed nicely, the osteotomy didn't heal, which is fun. Schatzker proposed a nice technique actually of preoperative planning, in which they routinely outline, do X-ray of the normal side, then the radiograph is turned over, traced, and the fracture line marked in, and then they plan external fixation. it's actually they plan to this should correspond to the final radiograph. They do wires first for provisional fixation, then followed by 3 or 3.5 millimeter cancella screws for and then dynamic compression plates, screws across the fragments for intrafragmentary compression, and then screws here 7 and 9 are actually load screws, and then they fill the remainder of the fixation. It's it's a good technique if you're planning one of these. What we tend to do, and that's actually the current teaching we're having, is actually convert the distal fragment by fixing it, making it a single fragment, so converting it from C to the simpler to the simpler forms, and that was described in 1972. And by doing so, you open the fracture, you reduce it with a clamp, fix it provisionally, and you can do your osteotomy if you want to, and then fix it finally by pulling the screws. First, interfragmentary screws through the plate, the 8 commands, and then fill the plate. That's how we approach it. Always identify the nerve. This is a very nice paper and book chapter actually about which approach to use in which of these fractures. Green is recommended, yellow is possible, red don't use. Here, so what are the approaches? Olecranon osteotomy, we've discussed that. You can always access the distal elbow, so the distal humerus, through different approaches. What I've described is actually the trap, which is triceps reflecting and collineus pedicle, but you can take a fleck of bone with it. Here you can see actually the triceps splitting approach. I don't think many do. You can do the tongue or V-shaped approach, but evidence says that these patients have weak triceps function. Brian Mori here actually in this approach, they use space between the space between the FCU and the anconeus, or you can use the olecranon osteotomy. So physiotherapy and all of these, always these are two important papers about elbow trauma. However, generally speaking, you should, I personally aim for no plaster, no slab, start mobilization as soon as we can. If I'm worried, I'll give the patient a hinged elbow brace. We leave the patient in a back slab for the first 2-3 days, see them for physio, see them, check the wound. And the best one to dictate the line of treatment isn't X-ray, it's actually the surgeon himself, because the surgeon is the one who can attest the stability and the quality of the bone. So we should always aim for early mobilization in elbows whenever we can. Thank you.
Thank you so much, Mr. Imam, for this wonderful talk, summarizing all the distal humeral fractures. It was a very interesting talk, sir.
Oh, it's my pleasure. Thank you.
Thank you so much. We have many attendees on Zoom and on Face. It's about 800 on Face now, and on Zoom about 100. This signifies how much the presentations are very valuable.
Oh, it's a pleasure to be among all these eminent surgeons from all around the world.
Thank you so much. Dr. Ahmed Sheikh,
thanks, Mr.
would you please moderate the questions?
Yeah, absolutely. Thanks so much, Mr. Imam, for this great presentation. You have highlight of this difficult situation, which in the back of our minds, distal supra-interhumerus, it will end up in stiffness in most cases, unfortunately. So it's a very, very serious to plan it well, to have this very good outcome. Got one question here about using double plating. He asks about, should the plates be at the same level, or can one plate be longer than the other?
So it's a very good question. It's all about fractures. So the fun of trauma surgery is that you plan your surgery among different patients. It's a bespoke treatment. So with elective surgery, I can repair 10 cuffs blindfolded, but with distal elbow fracture, I have to look and assess. So if the fracture is extending more proximally, you can always go more proximally with any plate. So all what you need to do is to make sure you restore the fracture as an articular surface. You have good construct with interdigitating screws, stable fixation. I tend to test my fixation at the end of my fixation in order to allow for early mobilization. If you don't mobilize your patients, the fracture will heal, but they wouldn't be able to use their shoulders, sorry, their elbows. And so basically, it doesn't really matter. All what is really matter is the axes, sagittal and coronal axis, and you can use longer plate if the fracture needs a longer plate. You have to fix each column by at least 2 screws above the fracture.
Yeah. A following question to this ask about is different lengths to avoid stress riser. You think that one shorter and one longer plate, just not for the two plates will not stop at the same level, so this will be a stress riser. Does it make any sense?
You know, with loading, it's a, you know, stress risers isn't a major problem in humeral compared with distally, but actually that's one advantage, and that's why, you know, before fixing my plates, I look at the fracture geometry. If I need to make one longer than the other, you can use different planes, which is the orthogonal plates. If you're going to do 2 parallel plates, you can avoid that by having the plates by having the plates adjusted according to the fracture.
Yeah, yeah, perfect. A good question about arthroplasty. Just to mention that Mr. Singer, he had a fellowship with Prof. Frostic in Liverpool, shoulder and elbow arthroplasty, and myself also. So we both knew that elbow arthroplasty is a good solution, but let's take it cautiously. The question is about why it's rare. So just want to highlight that it's not magic.
No, it's not rare, but it's actually we do it more and more. Hemiarthroplasty, I do it. I have very low threshold in elderly population to do hemiarthroplasty, just replacing the distal humerus. If someone has pre-existing arthritis, I'll do an elbow arthroplasty. But we have to understand the patient, the demographics. Elbow arthroplasty is mainly, and that's sad, unfortunately, only indicated for low demand patients because you cannot carry more than 5 kilos. So if I see someone who's 60 or 70 years old, 50 or 60 years old, I'll attempt to fix it. But if I have an elderly lady who's 80 years old, then elbow arthroplasty would be ideal. Someone with rheumatoid arthritis, elbow arthroplasty is ideal. So actually, we do in our center few of elbow arthroplasty every year for this type of fractures, but it must be for the ideal patient. The thing that I didn't mention as well is non-operative treatment. So if you have, so it's unlikely to do that. We've just managed one few weeks ago non-operatively, but this patient has the chronic dislocation, dementia, Alzheimer's, a lot of problems. So it was sensible just to do soft cast for protection, aiming for fibrous non-union. But usually I wouldn't attempt, we wouldn't go for that route as well. But total elbow arthroplasty is a very good option for elderly multifragmentary fractures.
Yeah. I think we are done with questions, but one last question from myself. Being working in a unit which is Elizarov friendly, any place for Elizarov in distal humerus fractures?
So one thing also, because I did, for the first questions, I forgot to mention, I tend to make one plate above the other plate or longer than the other plate in order to avoid the stress riser, because I didn't highlight that. But it's all about the fracture, so the fracture geometry. So the frame for distal humeral, Mr. Khalil is one of the highest volume surgeons in the UK in putting frames. I've done external fixator there, but I'm not sure about Mr. Khalil experience about frames.
Mr. Khalil, yeah.
I am the world's laziest surgeon. So if somebody else can solve my problem, I would rather know. So you look at the problem and you look at the patient, and basically that's the guiding philosophy is that we shouldn't do more harm to the patient. So usually you have a patient that has had 1 or 2 goes. So if there is sometimes the decision is made for you. If there is infection, I don't think even my clever colleagues will put implants. So we then have to resort to basic surgery, which is excision, holding, debridement, and antibiotics, as I showed that case. If you have a well-fixed implant and all you have is a problem with bone failure, then you would want to preserve the implant and try and achieve union. So no, we use whatever carries the least risk. So what my colleague mentioned was one of the best things that we can do is to shorten the humerus, because what that allows to do is it takes away the tension and it allows because the distal femur is a thin edge. If you just excise that, you actually achieve very good contact area. And one of the best things, sorry, I'm going to take 1 second. One of the best things on that set that you have of any make is the posterior lateral plate. So if you do shortening of your distal humerus and you put that posterior plate on the humerus, it actually tells you where your articular mass should align. Okay? So if you get stuck anywhere and you have done your articular and you don't know what to do, shorten the humerus, distal humerus, put that plate on, and inshallah that will be very helpful.
Yes, and I don't think, in any of the fractures we've seen, we saw that, because it's either you can reconstruct it, as Mr. Khalil have said, it's mainly if it's infected, and then you can consider that, but it depends on how bad the fracture is. If it's an open fracture, when are you going to interfere? So even plate fixation would be doable on most.
Thanks so much, Mr. Imam, for such a rich discussion. I really enjoyed it myself, and thank you, Mr. K, also for sharing your experience. Thank you.
Thank you so much. Thank you so much, Mr. Imam, for this wonderful presentation. And it's our chance to see you again tomorrow, inshallah.
Inshallah. My pleasure.
Yeah, thank you so much, sir. Now.